My speak in the next 5 minutes will be about comparative guidelines between open and laparoscopic partial nephrectomy. First, I have no potential conflict of interest to report. The purpose of partial nephrectomy is to provide negative surgery margins, maximize renal function preservation, and minimizing the morbidity related to surgery. The goal of minimally techniques is to maintain the oncological efficacy of open surgery while reducing its morbidity. The NCCN guidelines authors show that functional and oncological outcome for laparoscopic versus open partial nephrectomy appears to be similar. Many publications and many studies showed the advantage of minimally invasive techniques when compared with open surgery. In these two studies, comparing laparoscopic and open surgery, Engelbert, Jill, and Edward Long showed that laparoscopic partial nephrectomy was associated with shorter operative time, less blood loss, and shorter hospital stay. The intraoperative complication was similar between two groups. However, with laparoscopic partial nephrectomy, there was longer ischemia time and increased number of subsequent procedures. Concerning oncological outcome, Brian showed that 7-year metastasis-free survival was similar between laparoscopic and open partial nephrectomy. As a result, the NCCN guidelines conclude that T1A and T1B stage should be managed by partial nephrectomy, and both open and laparoscopic approach can be considered depending on tumor size, location, and surgery and surgeon expertise. Let's go to the EAU guidelines. Many multiple studies show when comparing open with laparoscopic partial nephrectomy that there is no difference in terms of progression-free survival, and there is no difference in terms of overall survival. Operative time and one ischemia time are generally longer with laparoscopic approach, while postoperative mortality, deep vein thrombosis, and pulmonary embolism events was similar between laparoscopic and open partial nephrectomy. EAU guidelines compared also the open partial nephrectomy versus robot-assisted partial nephrectomy. And in this first publication of Alexandra Lecomte, she shows that robot-assisted partial nephrectomy was superior to open partial nephrectomy in terms of lower estimated blood loss and shorter hospital stay. Work ischemia time, operative time, variation in creatine levels, and pathologic margin was similar between two groups. And in this French multicenter prospective database, Benoît Perronnet showed that with robot-assisted partial nephrectomy, there was decreased morbidity, less major complications, less transfusions, and shorter hospital stay. And if we compare now the open versus robot-assisted versus laparoscopic partial nephrectomy, after 5 years of median follow-up, similar rate of local recurrence, distant metastasis, cancer-related death rates was concluded. To summarize and conclude the EAU guidelines, partial nephrectomy can be performed by either by open, pure laparoscopic, or robot-assisted approach based on surgeon expertise and skills. But minimally radical nephrectomy should not be performed for patients with T1 stage, for whom partial nephrectomy can be is feasible by any approach, including open. Finally, the American guidelines are aligned with the European one. Minimal robotic and laparoscopic partial nephrectomy have similar surgical margin and oncological outcome than open. The benefit of minimally invasive techniques is at short-term and perioperative period, and is similar to open partial nephrectomy at intermediate and long-term follow-up. The potential increase in cost observed by minimally invasive technique can be balanced by the shorter hospital stay and the earlier convalescence. Ultimately, clinicians should employ minimally invasive approach only when oncological functional and perioperative outcomes are unlikely to be compromised. To conclude, both techniques open and laparoscopic partial and the mini-invasive partial nephrectomy could be proposed to our patients. However, with laparoscopic partial nephrectomy and robo-assisted partial nephrectomy, we have shorter operative time, less blood loss, early convalescence, and less complication. Thank you.
The hospital in Tunisia, in South Tunisia. We already say guideline. Guideline says you have to perform partial nephrectomy.
Okay, Dr. Ghadouane.
Thank you, Mr. President. I'm happy to be here with you in Amsterdam to share with you this clinical case about locally advanced prostate cancer. My name is Dr. Jandouzi. First, I have no potential conflict of interest to report. This clinical case is about a 73 years old man who was suffering from bacteria and difficulty in urinating. In the digital rectal examination, we found an enlarged prostate and a third left nodule plate staged T2B. Initially, the PSA was 28 milligrams per milliliter. In the MRI, we found enlarged prostate and the signal of normality of the left peripheral prostate bias 5 extended to the base of the left seminal vesicle. The right vesical signal was Indian, and we had no adenopathy. So, to stage this patient, it's T3B, N0, MX. Therefore, we performed a prostate biopsy. We realized 12 samples in each lobe, six left and 6 on the right. The pathology was prostatic adenocarcinoma, Gleason score 7, 3 plus 4, so it's EAU 2 in the left median and the left base. So, according to D'Amico risk classification, this is a high risk, locally advanced prostate cancer. So, for imaging, we performed classical imaging. It's a bone scan and thoracic abdominopelvic scan, which showed no evidence of secondary location. For PSMA PET scan, it can be useful, but we don't have it in our structure. So this is the recommendation in the EAU recommendation about imaging. So we have in high risk localized or locally advanced prostate cancer, we should obligatory perform at least cross-sectional abdominopelvic imaging and a bone scan with a high level of evidence. The treatment that we propose to our patient, according to EAU recommendation, we can use both radical prostatectomy or radiotherapy associated with hormone therapy. Radical prostatectomy, in this case, should be realized as a part of multimodal approach. So this is the treatment that we propose for this patient. Why? Because the patient was in good shape and his life expectancy was more than 10 years with no evidence of secondary location. So we performed a radical prostatectomy, and the pathology showed that the two lobes affected prostatic portion parenchyma largely dissociated over the entire head of the left prostate, located intra and extra prostatic. The EAU is now 3. We had the EAU 2 at the biopsy, now it's EAU 3. We had also a perinervous envelopment. The base of the left vesical signal is tumoral, and in the lymph node dissection, in the right we had no involvement in the nodes. 6 out of the 6 were negative. Were negative. On the left, we have 1 node positive over the 7. So if we have to stage our patients, this is we can stage as T3B, M1, MXR2. This is an aggressive pathology. We have several worse criteria. We have a T3B disease, N1 disease, and R2 disease. The PSA that was performed 1 month out after the radical prostatectomy was 0.28. This is a persistent elevated PSA after radical prostatectomy. So we performed as the multi-modal approach. But after prostatectomy, we performed radiotherapy associated with androgen deprivation therapy. The radiotherapy was a 3D conformal mode, 60 grays in 33 fraction of 2 grays per session. This radiotherapy concerned the prostatic bed and the ganglions. And we use the hormonal therapy that we associated in androgen deprivation therapy for at least 3 years. And after the initiation of the radiotherapy and hormonal therapy as an adjuvant therapy, the PSA level dropped to 0.07, which is undetectable, and this level remained stable so far until now with 2 years. Thank you for your attendance.
We worked very hard, I must say, and all the congratulations and the presentations on a very high scientific level. Of course, we discuss all the possibilities.